this part, when I talk about PSMA radioguided surgery and PSMA radioligand therapy, this is probably a lot more controversial than the first part, because now we're talking about really small patient numbers, limited experiences from our side, and also from treatment, which is, of course, again, outside the guidelines. But maybe, yeah, you'll see why we believe that also these options will maybe have a place in the future. We have talked about that PSMA-PET is able to detect prostate cancer earlier than other images, like here in this lymph node that lights up. And I also showed you this image showing that here with choline PET you have detection rate between 1 and 2, 43%, and now we're at 95% in the same PSA range. And now what we see sometimes is now those small lesions that we think are prostate cancer metastases. However, these are located totally where we don't expect them to be. It's outside the normal template fields. Here, in this case, is in the pararectal fatty tissue. It's a small lymph node. When you do surgery and go for those lymph nodes, you might not find them. Before the PSMA era, when we did those kind of surgeries, we performed a frozen section analysis, sent it to the pathologist. The pathologist said, well, there is cancer, then we were very happy, and then they said, well, there's no cancer inside, and then we said, well, then we need to look again. So in some cases we could not find the cancer lesion, and with the PSMA-PET imaging, in a moment I'll talk about surgery, but we have now also the possibility to be more targeted, and in this case for radiotherapy. This is a patient who, after radical prostatectomy, PT3A disease, no lymph node involved, Gleason 7, and had a PSA rise to 0.5 nanograms per ml. And so they performed a PSMA-PET and found here this lesion in the rectum, like in the rectum mucosa. They did endoscopy, cut it out, and here you see PSMA immunohistochemistry, and here you see the immunohistochemistry for the intestines. So we have here a rare case of a mucosal metastasis of prostate cancer in the rectum. And this enabled now to do a radiotherapy with boost on this node. Otherwise, of course, you would have radiated also in the prostate bed, but maybe this nodule would not have gotten the dose it was necessary to. And after salvage radiotherapy in intensity modulated radiotherapy technique, he had a complete PSA response, and until now is PSA 0. So we were very fortunate in our institution that our radiopharmacists, they developed not only PSMA ligands for imaging, and I talked a lot about PET imaging with gallium-68 PSMA, but they constructed this PSMA INT, they call it investigation therapy, and there's another one, INCS, investigation and surgery, so different molecules which can be labeled now with different radioligands. And I will talk in a second part about targeted radioligand therapy using PSMA INT, and which is then labeled with lutetium-177. And you can also label it with indium-111 or technetium now. Technetium, you all know it from bone scintigraphy, which both are gamma-emitting isotopes. And you can do SPECT imaging with those gamma traces, like from bone scintigraphy, or you can do radioguided surgery. And this is what I want to talk to you about in the next few minutes. How does it work? PSMA radioguided surgery. You have, the patient gets injected a dose of 110 to 150 megabecquerel when we used indium-labeled PSMA ligand, 24 to up to 48 hours prior to surgery. You then can perform SPECT-CT imaging to ensure, as quality control, that you still have the lymph node found. And then when you do surgery, you can use a gamma probe and giving you a signal basically back if you found the node. And now here's a little movie, two little movies highlighting it. Here you see a lymph node. This is obviously enlarged. This is suspicious, but just for the sake of showing you how it works. This corresponded then to this lymph node. This is again PSMA immunohistochemistry. This is about 1 centimeter, and it was also palpable. After removal of this lymph node, which was the only finding on PSMA-PET in this patient, we did intraoperative scanning with a gamma probe, and then behind the vessels we found another fatty tissue specimen, and here we also got positive signals, and this again is 1 centimeter. So we have this little metastasis that was not detected by PET, but by intraoperative measurements with the gamma probe. And how does it work? You do have some background sound. So around the vessels, it's like a little bit Star Wars in your arm. You do have some background from muscle and from vessels, but you clearly can identify this node. And the good thing is now we don't do frozen sections anymore. After removal, we can directly move away from the patient and measure it again. And this is now this little movie. So there's nothing there. So you know in this fatty tissue there are some things, some lesions. So you can really screen, have you found your node? And you screen again, of course, in the patient, in the surgical field, do you have any additional lesions?
How long is it detectable after injection?
That's a very good question. Indium-111 has a half-life of 2.6 days. So first we started a 1-day protocol, 24 hours afterwards, doing surgery. Then we had still a lot of background. In the last 2 or 3 patients, we went to 48 hours. You have less background, you still have detectable, but we changed that to technetium, and I'll explain you why and then how it works there. So this is the first series that we did. I started first surgery in April 14, and these are 30 consecutive patients, and the inclusion criteria, of course, is a positive PSMA-PET scan. Only 1 or 2 metastatic lymph nodes. PSA median 1.3 nanogram from 0.2. One had at the time of surgery then 30.9, which is probably too high, which are good criteria. So we don't know yet. So what I propose is, of course, solitary lesions. It's probably better to have the lesions located in the pelvis versus the retroperitoneum, because the metastatic route has been traveled longer. Low PSA, low velocity, if possible, Gleason score better, and maybe longer time interval after primary therapy. I don't know if this is true, but this is what I'm supposing. How about the comparison between PET and SPECT? Here you see the PSMA-PET MRI. In this case, you see this nodule lighting up in this patient with PSA 1.33 nanogram per mil, and here you see the SPECT image. What you can see, SPECT-CT or SPECT imaging is not as clear because of just how it works. Gamma radiation goes everywhere, and you can still calculate, okay, it might be from this area, and PET is very more specific. You have a better resolution. So you see here the nodule is nicer seen. And you do have just more halo in the SPECT imaging. But also, SPECT-CT does not detect every nodule. So we know from PET, he has here the small lymph node, and there's only very, very faint signal in the SPECT imaging. So when we compare, we analyzed here 22 patients, PSMA-1, 0.2 to 7.2. We found 29 positive lesions in PSMA-PET, but basically half of the lesions were not detectable by indium PSMA SPECT CT scan. That does not mean that they don't take up the tracer, but just the imaging, because the detectors are outside the patients, does not take it up. It's the other way around when you go then with a gamma probe inside the patient and measure, and here again is another intraoperative view which gives you an idea. This is just the fat tissue in the pelvis, and you can basically palpate nothing. I mean, you do have the images, you can look where the node is located, but now when you scan, you can clearly then see how you find those lesions. So you have a little bit of background. This is the long of the movie. And then you know where to go. And this is especially useful. I find it especially useful when you're outside your urological comfort zone, when you go pararectal, presacral, interorthocaval or something. If you have some guidance, this is, I find it very useful. And also, we don't do frozen sections, which saves us at least 30 minutes time. So in 29 of the 30 patients, we could detect all the positive lesions. In one patient, we missed it. It was a patient with really a tiny nodule, PSA of 0.4. But this was one of the first cases also. Until now, I did surgery on more than 90 patients.
I have one question. You speak about that you take patients to this surgery, only those who have positive PET scan.
Yes.
And you just said that you have 48% more positive when you use it intraoperatively, which is not seen on PET.
No, I'm sorry.
This
I didn't make it clear. So we have PET and we have the SPECT imaging before we do surgery.
Let me see by gamma camera.
positron.
Okay, and we see that the PET is better than the SPECT.
Than the SPECT, okay.
And now you could argue, well, then you don't find it intraoperatively. It's not true.
No. I just saw that why don't, for example, we use this intraoperative tracers even if the patients don't have positive PET scan.
Oh, no. So the inclusion criteria for every patient is, of course, I mean, these are very highly selected patients. They're in good condition. Otherwise, they go on hormone therapy then, and they have a long life expectancy still. And they ask, is it possible another local treatment? And then they have 1 or 2 nodes in the pelvis. And then I say, well, this is completely outside the guidelines, but maybe this would then be a possibility. And intraoperatively, I detect all those lesions. So the one patient was one really of the first patients where we could not find the lesion. And when we now compare the measurements and the histology, we see 48 tissue specimens were positive on measurements, and on histology, and 87 were both negative. In 4 tissue specimens, we could not detect the metastatic lesion, additional metastatic lesion. These were really tiny 1-2 millimeter lesion that were nearby, but we, of course, also here, also with PET imaging, we do have a lower resolution, so we won't detect just some single cells, of course, with this kind of surgical procedure. In 6 patients, and this is probably also a problem with indium, with a background, with a higher background, and later I'll talk about technetium. We found that we have positive tissue specimens, but histology turned out negative. So what about them? There were 5 with only a low count that we thought is positive, 1 with an intermediate signal intensity. So there were just those tissue specimens where you don't really need. And then also, here have been like 10 tissue specimens. We asked the pathologist to look again. And then 4 of those tissue specimens were positive then in histology. That means also, of course, the gold standard of histology is not always as golden as we think it is. So it's really, I mean, I have to say these are false positives, but sometimes it also can be difficult to analyze in histology. And during radioguided surgery, we even found additional lesions up to 2 millimeters small that were not seen on PSMA-PET before. So what are the PSA response rate in those patients? I mean, these are patients who have metastatic lymph node metastatic disease. And then when you look at the PSA change from baseline, you see that over 50%, over 70% have a decline over 50% of the PSA, and in 50% of patients we see a decline over 90% of the PSA, and a decline of PSA below 0.2 we see in 60% of patients. What about treatment-free survival? 33% of those 30 patients received cancer-specific therapies after median 125 days. And the rest is treatment-free after median 340 days. I think if somebody will relapse after the surgery, it's probably more like an early relapse, and it will hopefully level out. So that means we have here maybe a chance to even provide cure, or at least a time interval without therapy to those patients. So what are the disadvantages of indium PSMA ligands? Indium is expensive. For one patient, just indium is like around 1,000 euros for us. Also availability. We don't have it on site, so it has to be shipped to us. It's icy outside on the streets, and the cars can't run, and so on. And of course, we do have radiation exposure, not only for the patient, but also for the surgeon. So we changed now since last August to technetium PSMA ligands. August 15, 2015. It's a lot cheaper. Technetium is really, it's not expensive. Technetium is everywhere available and has also a lower radiation exposure. And this brings me back to your question before. Technetium has half-life, I think 6 hours, 8 hours, something around this. So when I do surgery the next day, there are already 3 half-lives are gone. So I do have a lot less background activity, and so less radiation exposure also. And here I can only talk now about 9 patients. PSA 2.3 median. And these are the first results. Again, the radioguided surgery evaluation with histology, 50 positive, both positive. No specimen was positive, and histology cancer was present. There were also 4 tissue specimens that were negative, but again, here in those negative tissue specimens, these were 2 patients, one with 3 specimens and one with one specimen, and the one with 3 specimens was done surgery after 24 hours, so probably too long. And the dose of technetium PSMA that this one of the first patients got was very low, so probably this could also add, and the other one had also micrometastasis that was not detected. So to summarize this part about PSMA radioguided surgery, these are very early results, of course, but in our hands, it enables detection and removal of those small metastatic lesions that might be atypically located, and I have to say it might positively influence oncological outcomes of course, highly selected patients. I think with this technetium-labeled PSMA ligands, I think and I hope that this technique will also spread. Suitable patients, identification of the suitable patients is surely critical. And of course, PSMA-PET imaging showing one or two lesions, this is the entry ticket, let's say, for this kind of approach. Therapy in prostate cancer, after local therapy, you can, if you have a relapse, you can do ADT, hormonal treatment, then you have other medication, abiraterone, enzalutamide, radium-223, maybe then chemotherapy, docetaxel, cabazitaxel. Can we add here something? Do we have another option for this patient? This is not a bone scan, this is again a PSMA-PET scan showing really a patient with diffuse metastatic disease. And this is the first report from Heidelberg, from the group from Zechmann. And they used a PSMA radioligand with iodine, 16 patients with one cycle, and this is of course a high activity that they get injected, 4.8 gigabecquerel, and this is the waterfall plot in those highly pre-treated patients, and this is one patient example that you see here, this is one patient and this is one patient, before and after, and you see quite some responses can be seen in those patients who basically had every line of conventional therapy. So what are other ligands? This is the PSMA ligand which is used in Heidelberg. This is the ligand that we use in our institution, but as I showed you before, they all have the same moiety. And now I will mostly talk about, there's really not a lot of literature around. This is one paper from our institution about lutetium-labeled PSMA ligands for therapy of those patients. And I will just walk you through the publication, and then in the end telling the results of other groups, but really there is not a lot of literature available right now. So what are the patients? Which patients do we offer this really experimental therapy? Of course, he has to have prostate cancer, castration-resistant prostate cancer, even under ADT, of course, tumor progression, and previous treatment also with abiraterone and enzalutamide and a taxane-based chemotherapy. Should not be eligible for radium-223. So basically has all the conventional therapies. These are the patients with not really a lot of options. Again, a PSMA-PET scan is mandatory to see if those metastases have a PSMA, show PSMA expression. Eco performance status should be okay. And renal function, this is what we were concerned about, also the uptake in the kidneys, because the tracer is excreted through the kidney, and we were concerned about kidney function, that this radioligand therapy is hurting or is damaging kidney tissue, and that's why we took this in, which might not be the case, at least after in our patients after this follow-up, then adequate bone marrow function. Exclusion criteria: infection or hepatitis, and then heart disease, brain metastases, and then other malignancies. So like the exclusion criteria which are found in most other chemotherapy trials as well. How is the treatment performed? So we have a screening phase, we have a PSMA-PET CT. We did in the beginning also a clearance, so to calculate renal function, bone pain inventory, then treatment. This is 1 to 4, the patient is in the nuclear medicine department receiving the injection. We have lab tests, we have a scintigraphy, you can also do with this lutetium, PSMA ligands. You can also do scintigraphy to see if it accumulates. Then you do lab tests, scintigraphy, controls. After 6 weeks, this is how we did it, another PSMA-PET CT scan for comparison. And then we have, after each cycle for each patient, like a board meeting, and say, do we think this patient is profiting from this therapy approach? How is he doing? Echo, PSA value, imaging. And then if we decide he has a reasonable therapy response, we repeat the therapy every 8 weeks up to 4 cycles. This is what we did for these patients. So we can report on 22 patients. PSA median was 350, mostly ECOG 1. And here you see all the different systemic treatments that the patient got. So they were heavily pre-treated. Docetaxel, almost all of the patients, cabazitaxel, abiraterone. So you see prior lines, 2 lines, 36 patients, mostly 3 and 4 lines. Sites of metastases, almost all had bone disease, lymph nodes, liver, lung. And in the first 3 patients, we had a lower dose, 3.7 gigabecquerel, just to get a feeling and not to hurting the patient. And we looked, do we have any relevant toxicity? And then in the remaining 19 patients, we treated with 7.4 gigabecquerel. And this is now one example of patient with complete response. We have in those 22 patients, 1 patient, and I show you the images, which had a complete response. There was a 71-year-old male with 6 cycles docetaxel abiraterone. He had radium also. Good echo performance status. PSA was around almost 800. And then he got here first injection, second injection, third, fourth. And here this is alkaline phosphatase levels, his PSA levels, and LDH. Here are the images of these patients. You see the CT, you see the PSMA-PET, and you see the fusion image. And here again, the whole body image, the maximum intensity injection. He has now improvement of his clinical performance status, and we observed no adverse events in this patient. And right now he's off treatment. He does not even have hormonal therapy. So this was one exceptional case. You can also have this kind of case, of course. Progressive disease, abiraterone, 9 cycles, cabazitaxel. He had 1 cycle, lutetium. He had new liver and new bone metastasis. This is before and this is after. And in this patient, of course, we said, okay, he is not profiting from this type of therapy, so we excluded them. These were the adverse events in the 3 patients with a lower dose. So we see no grade 2 to 4 toxicity. We see anemia, thrombocytopenia, mildly obstipation, loss of appetite. In general, also in the other patients, we don't see any grade 3, 4. We only see 1 or grade 2 toxicities, which when you compare it to a treatment with docetaxel or chemotherapy with cabazitaxel, are actually, it's very well tolerated, this kind of treatment. So we actually are really happy that we also have this experimental line of therapy, but that we also have this option for those patients. These are the PSA responses. We see a decline over 50% in a third of patients, and this was maximum PSA change, and week 8 PSA change over 50% in 24% of patients. Progression-free survival and clinical response. median time to PSA progression was 175 days. ECOG improvement, well, most of the patients were stable, some were worse. Bone pain, and this was also reported by Zechmann, by the first publication, that a lot of patients saw that their bone pain was really diminished, was less. And this is the time from the treatment-free survival. So even in these patients, we get responses. So this is another publication from Bad Berger by Professor Baum. He had 56 patients, 25 with 2 cycles, and up to 5 cycles, PSA median 43, and he also found a PSA decline over 50% in 59% of patients. Another publication, I mean, these are all small numbers like ours, 24 patients, PSA decline 42%, and here you see one of the cases showing also almost a complete response, but at least a very good partial response. This is then the other ligand, that Heidelberg compound that they use. They combined 4 centers with 74 patients, PSA 340 in 31% of patients, over 50% PSA decline, no relevant toxicity. And another one, just from Heidelberg, 30 patients, also here, good PSA declines. So this is really all the data that there is out up to now for PSMA radioguided ligand therapy. These are only retrospective case series, but what we can say, nobody reported high toxicity, so it is probably really a targeted radiotherapy option for those patients. It is, of course, experimental, but we see considerable anti-tumor effects with PSA declines from 25 to 60% of patients, declines over 50%. But we have to start, of course, prospective trials as with imaging to get them into the guidelines, these kind of treatments. So again, there are a lot of people involved in all these trials or studies. And yeah, I thank you for your attention.